Wellington, Brain and Spine, and all the people who have actually supported this. My name is Dr. Emeka Okor. Next slide. So I provide private care in this place called Citadel Medical, somewhere in Kwaimpa area, where we provide complex brain and spine care with very fantastic outcomes. Next slide. But actually, I'm going to be talking more about the public healthcare space today, nothing private. Okay? Yes, in the last 15 years or so, last 15, 20 years, the private sector in Nigeria has pushed the boundaries of availability of complex care. Okay? So one of the things I say is that up to 90% of patients who need neurosurgical care in Nigeria do not need to go to India. It can be provided here in Nigeria. But the problem is that when you look at the public sector, okay, it is still a very big struggle in terms of even the availability, but specifically with accessibility, okay, and affordability. Okay, so who agrees with this? If you agree with this, say yay. If you agree with this, say yay. Yay. If you disagree, say nay. Okay, the years have it. So we all agree that in a limited resource setting like ours, okay, to actually get a neurocritical care special space and stuff like in our public hospital, it's almost a no-no, isn't it? So let's agree with that. Now, what I want to do today is to actually, I just picked some areas in neurocritical care and say, okay, this is what it is like in Nigeria. Okay, how can we manage ourselves? And that's what we're talking about. One of the things I tell people is that I don't talk theory, I talk real life, practical. Next slide. Okay, so these are some of the things I'm going to be talking about. I'll give you 2 seconds to actually read them. So, infection and prevention control, ventilator mode specifically for a subset of patients. Okay, BP settings and how we actually do modulation with it. I can see a lot of my ICU nurses here. You know, ICU nurses that work with me. So they will understand some of these things. And of course, this one is critical, the timing of doing this emergency stuff in a public hospital. Please, guys, remember, I'm talking about a public hospital in Nigeria. Please remember that. And of course, the issue of multidisciplinary care. Next slide, Nehemiah. Okay, so I'm just going to go. So, public hospital. These are some public hospital cases. This chap is about 51. Main issue was actually seizures. Came in our public hospital, had this removed, and you can see the before and after scans. Seizures in the last 1 year, no seizures. Next slide. Lady in her early 70s came in, weakness on the right side, difficulty walking and stuff, using that right hand and everything. And then she has that CP angle going almost to the tentorial lesion that's compressing the brainstem. Okay? And post-op, you can see we've taken out almost all that tumor. Now she's walking well. Next slide. Remember, public hospital. Okay? This chap is 48, came in, previously had been having issues where vision is actually going out slowly, but all of a sudden, bang, sudden onset of headaches, and it has what called ptosis. Can't open the eye. And of course, if you manage to open, just double vision on that side. Okay? As a patient, you can see the before scan, the tumor there. That one is gone. You can see this, and you can see the before scan there. Okay? And now everything back to normal. Okay? Next slide. You can clap for that one. You can clap for that one. This is in a public hospital in Nigeria. This is in a public hospital in Nigeria. Next slide. Okay, this chap, interesting case. This guy's about 35. Okay, had some and then walked onto the road and got clipped by a car. Okay, came into the hospital quite late in the night, and they called me about him, and he was conscious, but he was a little bit confused. Okay, but then by the next morning, he had dropped to a point where he was not localized. He was unconscious. I had very bad seizures. Okay. We can see the big blood clot at the front. We can't see this stuff where he has some bruising on what we call the temporal lobe on that side. An epileptogenic area, okay, so that's why he had the seizures, okay? Now, luckily, the chap who actually hit this actually brought him in, so he actually paid for his CT scan. But after that, we have what we call the NEMSAS protocol in some of the public hospitals. The public hospital where I actually have that. So we actually shifted it to the NEMSAS protocol where for the first 48 hours, you're going to try and look after the chap, okay? So I personally moved him into the ICU. Hey, Then I spoke to the chap who actually hit him and said, oh, this is how much you're going to pay for this. And the guy was like, oh my God. So he basically ran away. Anyway, what happened, I had to, the next morning, somebody from, a guy who had operated previously, Dr. Ogumbo, remember him, I did that interhemispheric transconusal for him. One point he's in Dubai now. So he actually brought some money for this. And then I actually had to speak to the clinical director, speak to the legal team, speak to the social welfare, and pull everybody together. And finally, we actually did an operation to actually remove that clot out. And I've just discharged him this morning. You can clap again. Okay, next slide. Nehemiah is laughing because he knows the case. Okay, so this is a 51-year-old, this was in December. Came in and had that bleed, hypertensive lady refusing to take her medication. Probably they told her in the church that, that she's healed. So refused to take her medication and had this bleed all the hindbrain, the cerebellum, and it's closing up those water spaces where water flows through, and has developed fluid pressure, what we call hydrocephalus. Came in the night before. One of the key problems we have in a public hospital is the issue of timing of referrals and stuff, isn't it? Okay, but somehow they let me know the next morning, and somehow we jumped in and she was finally discharged. She's actually very well. Okay, let's go into what I want to really talk about. That's just to show you that in the public hospital, you can actually do stuff. But we have limitations, isn't it? From what that red thing that I said the first time. We have limitations. Next slide. Okay, so in January 2025, we actually got this in FMC. It's a very S88 system. Okay. The problem is that we don't have any link up. Where is Charlie? Maybe Charlie might help us to actually, because I think Charlie has this kind of system as well. Dr. Ungwai has this kind of system. When I'm operating, I'm the only one, and the person who's assisting me that can see stuff. Okay, everybody else cannot see, which is a little bit okay, but we have that, so that's why we can do some of the complex stuff that we're doing now. Next slide. Okay, so now I want to go straight into what I want to talk about. So let's start with infection prevention and control. I'm going to be specific about dress code. Dress code into the ICU. So for this, I'm going to actually categorize the staff. So you have staff. So those are the ICU nurses, the anesthetists. They are the ones who are inside there. Guys, you understand? I can see some of my people here. So you. So how do you dress? You wear something like this, isn't it? Something like this. This is how you dress. Okay. Then we have the next category, the visiting staff. I'm the visiting staff. The neurosurgeon is the visiting staff. I don't stay in there. I come and see my patient and I go out, isn't it? And the last category is the visitors. It's very important that we categorize these people. One of the major problems in this part of the world is this thing, this philosophy, this is how we've been doing it. It's a big problem. This is how we've been doing it. You don't want to try new things. You don't want to innovate. Anybody who brings them, no, we've been doing it like this. My question is always, you've been doing it how well like this. Next slide. Okay, let's go down to basics. How is infection transmitted? Basics, we go down, this is so basic now. Because I'm supposed to use a little bit of common sense. Yes, we can look at, do some research, but let's use a little bit of common sense. Contact. I'm touching him, contact. Direct or indirect, that's direct. So if he touches this, and I go and touch that, that's indirect, isn't it? Droplets. Like that person coughing now. Droplets. Airborne, some sort of droplets, but maybe the droplets are really, really small, so they stay in the air for much longer time. Average droplet doesn't stay in the body, you know, stay in the longer. Vehicle, through food, you're transfusing blood or whatever. Can you get malaria through transfusion? Can you get malaria through transfusing blood? Yes. Vector, can a mosquito bite you and get malaria? Yes. Can a mother transfer touches and HIV doesn't the child? Okay, so this is basic common sense. So next slide. Does this look familiar? In case everyone look at this, does it look familiar to everybody? Yes, sir. Does it look familiar to everybody? Yes, sir. Very well. It looks familiar, isn't it? Yes, sir. So let's analyze this, please. So this is it. This is equal to this, isn't it? And this is something new here. Okay? So let's analyze it. So go back one slide. So the main things we're going to be worried about in an ICU is maybe going to be contact and then maybe droplets, isn't it? And airborne, maybe. So if someone is coughing in the air or you feel that someone has a wet space, that's common sense. So our main thing, let's now go down to contact. Next slide. So for contact, which part of you is going to actually be touching the patient? Now let's go to maybe the visiting staff. So me, I'm coming to the ICU. Which part of my body is actually going to be in contact with the patient? Your hands. Thank God we all agree with that. Am I bringing this up later? This shoe cover, disposable shoe cover. Okay, next slide. Okay, so before I go to my proposal, okay, so go back. So this is actually reusable garment material, isn't it? Okay, so one person comes, wears it, and remember, it's below the elbow. Sometimes it reaches some people here, two of us. Okay, and it's reusable. So I come, I take it, I go into the ICU, right? Okay, finish what I'm doing. So imagine I am a visiting staff, isn't it? And I have 3 patients in that place. So I carry that thing that is here. I go to the first patient. Remember, it's long. I rub. I go to the second patient. I rub. I go to the third. Remember contact. Okay, then when I finish, what do? I drop it back here. Then Dr. Ogumbo will come and pick it up and go and see his own two patients as well. Contact. Okay, now imagine also that with this, maybe you finish with one patient, you say, oh, let me wash my hands. Okay, so remember it's here. You go and wash your hands. Water, wet it and stuff like that. You go to the next patient, you wash your hands again. Does it look like deceiving ourselves? Does it? Yes. Okay, so imagine I come in with my own clothes. My own clothes. Remember contact. Okay? I'm standing, if I'm standing if we're not worried about airborne or whatever, and I come with my own clothes from outside, okay? And I'm standing in the middle of the ICU. Am I in contact with any patient? Am I infecting any patient generally? No, okay. Now I want to go to a particular patient. I roll up my sleeves. Okay? I roll up my sleeves. I go to that particular patient. I wear a disposable apron that is extremely cheap. Okay? It's actually covering my front. Then remember, I'm bare below the elbow. I go like finish with that patient. I'm even wearing clothes. When I finish, I maybe wash my hands, take that one off, throw it away in that one, and then go to the next patient. Please, which one do you think is actually preventing the patient from infection? Wait. Okay, so let's go straight to let me try and be faster next time. So my proposals. Stop the use of reusable long-sleeve gowns. They have a high propensity to transfer infection. I have a running battle with my people where I'm coming from. In the public hospital, a big battle with this. Okay? Every provider, visiting staff, example me, I'm a visiting staff. Okay? Going to the ICU should be bare below the elbow. Go back. Bare below the elbow. Next slide. Bare below the elbow. And use disposable aprons. These are available and cheaper. And gloves per patient, and dispose them in the index patient's dustbin, okay, before moving to another patient and then using new ones. Wristwatches, jewelry apart from wedding bands should not be worn. Dangling earrings, hair not tucked in, tie not tucked in, and stuff like that, move them out of the way because it's contact. Okay? The use of shoe coverings crossing the red line is good practice. So those disposable, okay, maybe we can say if you carry your feet with dust from outside, maybe if you do this inside the ICU, maybe the hair will fall as well. Maybe. Okay. So we can continue next slide. Okay, strict enforcement of high hand hygiene with visible reminders in the doors and stuff like that. Again, if you are bare below the elbow, okay, it's easier for you to do your hand hygiene than wearing those things and stuff like that. They are terrible, absolutely terrible. Okay, of course, regular ICU training, disposable PPEs for patients or visitors. So we are not going to the visitors now. Disposable PPE. So instead of doing those things where everybody wears and comes, can put on all my sweat and all my bacteria and stuff dash to the next person and the next person and stuff like that. Instead of doing that, then if you have plenty of money in your ICU, then you can buy one. You can get a disposable for each patient, isn't it? For each person. But also, you can just say, guys, bare below the elbow and use your aprons as well. Okay? The medical teams in my hospital, they come in, they're like 8 of them. They just flood the place. So, for each unit, maybe a maximum of 4 people. And they audit every 6 months. Next slide. So that's the end of that. I hope I've been able to convince whoever is convinced. So ventilation mode specifically for raised, this is a very specific subset of patients. Patients with raised intracranial pressure. From anything. It might be from a spontaneous bleed, it might be from trauma, whatever it is. Okay? Now remember, in your public hospital setting, you know this is where you say, oh, we have this, we have that. Sorry, if it's not working, you do not have it. Do you have this a mobile ventilator? Yes, we have. No, you don't have it. It's not working. Can we agree with that? It's a big problem. It's a big problem. It's a cultural thing in this part of the world. Oh, we have it. No, you don't have it. If it's not working, you don't have it. Sorry. So the chance that you're going to have an arterial blood gas machine that can now measure your partial pressure of oxygen, partial pressure of in a public hospital is limited. So you need to. Okay, next slide. So specifically, the best ventilation setting for this patient is a volume control mode, volume assisted control. Because remember, what you're trying to do is not just oxygenate the patient, you want to ventilate the patient. You want to make sure that we don't accumulate that carbon dioxide in the body. So you want to ventilate properly. And the best, besides, in a patient who has been hit very hard in the brain and stuff like that, you want to really rest that patient. You want a situation where your machine is almost doing basically all the work. If I was in that situation, okay, people would say, God forbid, but for that situation, please rest me. Don't make me breathe small and do work and stuff. I just rest me for that period. Excellent. So, sometimes, when I say, okay, maybe we can use the SIMV VCV mode, the synchronized intermittent mandatory ventilatory mode. Where have you guys seen it? You guys, where have you seen me use that sometimes? Some patients will come, oh, they don't have money. Oh, they don't have enough money for midazolam and fentanyl. Oh, we can't really deeply sedate them. I say, okay, let's go somewhere in between. Because the key thing is that once you actually use this mode, you really need to paralyze. You need to at least deeply sedate the patient. Okay? So now and again, you see me. Remember, I'm talking about the nuances and the peculiarities, isn't it? You see me, okay, let's just manage SIMD volume. And I usually use that as a tidal volume, and you adjust your respiratory rate to try and get the PCO2 of that. Okay? And please, like we say, avoid very high carbon dioxide in the body. Okay? You titrate it, but one of the key things I see, especially in our ICU, in FMC, is that you start the patient on 100% FiO2. The next day you come, the patient is still on 100% FiO2. Why? Why? Huh? You titrate it.
The higher the oxygen.
Is it? Besides, you're even wasting oxygen. You're wasting resources. And of course, usually, the peak that on an average I will normally use is somewhere around 5, isn't it? Between 5 to 10. Next slide. Okay, so that's about the specifics in terms of that subset of patients that have significant pressure on their heads when you want to actually ventilate them. Okay? Sedation. Sedation, what do we normally use? Midazolam and fentanyl in this part of the world. Remember, we're talking about our own peculiarities, isn't it? There are different scoring systems. Well, tell me, guys, is this the one you use, the Ramsey sedation score? Is that the one you guys commonly use? So this is what we want. 6. 6. That's what we want. I had to now change. Usually I'll tell the registrar, the documenter, oh, please deeply sedate. Then one of the anesthetic registrars said, oh, what do you do? So and I said, no, medically induced coma. Document it there. I want a medically induced coma. Okay, for this particular subset of patients. Okay, remember, it's a subset of patients with intracranial pressure, raised intracranial pressure. Next step. Okay, blood pressure targets. Specific neurosurgical conditions. So, raised intracranial pressure from anything. Head injury, spontaneous bleeding, whatever it is. Okay? There's this formula. My ICU knows, you know this formula. You guys know this formula. One of the things I do in FMC is that I actually do multidisciplinary training. So I pull everybody together to try and talk to them about these things. Okay? So this is the amount of pressure that's going to push blood into the brain. That's how the blood gets into the brain. That's the pressure. This is the pressure from the heartbeat itself. And this is the pressure in the head. Okay? So for you to get this pressure that is going to help you push blood into the brain, okay, you're going to actually have to subtract the pressure in the brain from whatever the pressure is that's coming from the heart. Very important too. Now, in our public hospitals in Nigeria, can we measure ICPs, intracranial pressure? Can we measure ICPs?
Yes.
Really? Ben, yes. You can measure ICP. How do you do it? See, that's what I'm talking about, the peculiarities and the nuances. Okay? We are talking about, for example, we're in the era of medical negligence, isn't it? We need to understand that medical negligence is about standards. You understand? Using ICPs, especially measure pressure, is not a standard in Nigeria. It is not. You cannot cope. People are too poor. It would be extremely expensive to use ICP monitors. So what do we do here? So what we do here, you know, just like when the average Oyibo person will wonder, when you put your salt like this, how do you know that's the exact salt that you need? You just spray salt inside your food like this. You don't do it like the Oyibo people will calculate, 2 ounces of salt, 2 pounds of salt, but you just sprinkle your pepper and your, how do you know that is? So somehow that's what we do here as well, isn't it? So we look at the patient, we say, oh, what's the mechanism of injury? What's the patient's clinical picture? Then we look at the scan. Then we can gauge in our head. This guy's IC will be like 25. This guy's IC will be like 25, isn't it? Okay, so maybe I'll pick the particular patient. So maybe 25, so we'll put 25 here. Okay? So usually the perfusion pressure that we want is somewhere around 65, isn't it? 60, 65. Usually we used to say 70 in those days, but they brought it down to like 60, 65. So if I say 65 plus 25, what's that? 90. So you will see me in those studios, I'll tell them, I say, oh please, I want a map of 90, so I'm between 90 to 100. I'll tell them, I want a map. The numbers don't just come from anywhere. Well, we manufacture some of the numbers, but there's a thinking behind it. Then subarachnoid hemorrhage. Remember, we're talking about how to modulate blood pressure here. Subarachnoid hemorrhage. The problem with subarachnoid hemorrhage is that there's what we call vasospasm, where the blood vessels can close up and you can have stroke, isn't it? So if your blood pressure is too low, what happens? Stroke. Now, also if you have an aneurysm there that is ruptured and can rupture again, and you have a blood pressure that's high, what happens? So you don't have to modulate the blood pressure and get regular blood pressure. So again, that's why you guys see me when I say, oh, blood pressure target of this. Again, all these hypertensive bleeds, wherever they are, in the cerebellum, in the basal ganglia, wherever they are, stuff like that. Okay? Usually these patients come into hospital and their systolic blood pressure is what? 200. So the strategy with those kind of patients, relatively the same thing again. You don't want them to repeat again, but at the same time, you don't want to drop their blood pressure in such a way where you don't have enough perfusion of their brain. Okay, so even when you want to reduce that blood pressure, reduce it slowly over 6 hours. So for example, a patient comes with 230, I want to reduce that to roughly somewhere, maybe something about 150, 160 over the next 4 to 6 hours, slowly. And then I'll now set the target. So strategies, again, modulation. That's why ICU care, especially neurocritical care, is very difficult. You're modulating different things. So for example, a patient comes in and we say, hey, we want a MAP or a minute unilateral pressure of somewhere between 90 to 100, isn't it? But then we also need to hit patient with mannitol. We need to deeply sedate the patient. With your mannitol and deep sedation, will it bring the blood pressure down? Will it bring the blood pressure down? Will it bring the blood pressure down? No. Yes, it will. And they can run your trouble, isn't it? So please, don't be ashamed to use your inotropes when you need them. Because you're modulating things, isn't it? The patient needs the mannitol, needs the deep sedation, but also needs a good blood pressure. So modulate. Next slide. Let me try and be fast here now. Okay, timing of periodontals and the compressive period. Remember, I'm talking about a public hospital in Nigeria. Be very careful. Patient comes around 4 p.m. or 6 p.m. into the hospital and stuff like that, goes into the ICU and stuff like that. Lots of issues. You're trying to deal with this and stuff like that. Be careful about operating in the dead of the night and in the morning in a public hospital. Be very careful. Be very, very careful. So, what are the issues? Operating late at night or early hours of the morning. Logistic nightmare in a public hospital. Even trying to pull your resources together, equipment and stuff like trying to do pre-op planning and stuff like it's a nightmare. Very few staff on ground. Okay, team is not as sharp as they would have been first thing in the morning. Okay, generally lots of quality and safety issues with high chance of negatively affecting patients. Okay, but there are a subset of patients. For example, if you have a relatively young child that has a massive extradural hematoma, try and do whatever you can do. But if you have your standard patients, they come in by frontal contusions, a bleed somewhere and stuff like that, try and use the whole of the night to actually plan for the patient and go the first thing in the morning. I am telling you the truth. In a public hospital, a word is enough for the wise. Next slide. Okay, multidisciplinary team. Okay, we struggle with this in Nigeria. What is the basic thing that we do here in Nigeria? Somebody comes, they pack themselves, wear that long thing, they come. See the patient, they don't even talk to the nurses and stuff like that. They go and write in the system and they go away. Abi? Anyway, these are the people involved. You can add to that list. I'll just give you 1 second to go through the list. So for neurocritical care, and these are the key functions: comprehensive care, patient management. Everybody knows that that's one of the things. I practice what I preach. I don't just talk. Everybody knows that when I'm looking at a patient, you see me when I come to the world. I say, hey, where's the nurse? Where's the anesthetic registrar? I will actually reason with you. I'll reason with you. Let's look at this. I'll call Ushiju, the physiotherapist, and I'll actually tell Ushiju. I'll tell you, this is what the patient has. This is what we're thinking of doing for the patient. Communication and coordination, rapid decision in this kind of patients. You need to make decisions rapidly at some point. Okay, and of course, ethical end-of-life decisions. Every ICU nurse here and any anesthetic person who works with me knows that when you have a patient who, when you look at the patient in terms of outcome, when you look at the prognosis, is actually guided. The chance of that patient is really limited. You say, what do I do? I'll get the ICU nurse. I'll get the anesthetist. We'll go speak to the patient together. What does that do? It makes everything seamless. Okay? The patient's family are carried along. The nurses know what's happening. The anesthetic team actually knows what's happening as well. Everybody's on the same page. Okay? So when the patient finally goes, it's not surprising to anyone. Remember, teamwork makes the dream work. Can we all say that teamwork makes the dream work?
Teamwork makes the dream work.
Fantastic. Next slide. I think I'm posting home now. So remember that chap that had the bifrontal contusions? okay, where I say somebody actually donated some money for him. So this is a letter of appreciation for life-saving intervention. They always spell my last name wrong for some reason. My last name is OKO, not OKOH. Okay? So, but I requested them, please do a letter to the chap from Dubai who actually sent money to you guys to actually save this boy's life. But they actually did this as well. Now, look at this. The surgery was a resounding success, and our brother is recovering well. You are nothing short of a miracle worker and a true hero. That's talking about me. Seriously, guys, can only me do this? No, don't clap, I beg. Don't clap, this is a client. Can only one person as a news actually do this? No. So, yes, from a perception point of view, the family of the patient and the patient might be, oh, superheroes, but no one person can do this. Go back again. Go back. Teamwork makes the dream work. It is extremely important. Okay? Okay, move on. Let me just tell you my messages. So, a couple of messages. You know, in this whole thing where we talk about provision of care, okay, all these different factors that we actually need and stuff like that, oh, equipment, oh, building, oh, this and stuff like that. Guess the most important part is the factor. Which one is most important? It is human beings. Okay? That's why if you come to where I do private work and stuff, very small hospital and stuff, but will deliver bank absolutely good outcomes. You know why? Because the human beings are pulled together, it's like an orchestra. That person is playing the piano, that person is playing, everybody understands what they're doing. Okay? Leadership is foundational. To try and pull this kind of human beings together, part of this training and stuff, you need to show leadership and actually lead by example. Lead by example. And of course, attitude philosophy is everything. This issue of, oh, this is how we have been doing it. You don't want to learn anything new. You don't want to think laterally and stuff like that. Not good enough. Sorry. Communication is central and multidisciplinary strategy is the way. Absolutely, we said that. Innovative strategies are fundamental. Again, this issue of, oh, no, this is what we've been doing it. No, which day you just come here and that's what we do since now. Why you won't come on use your ring to spoil our blues? We must think innovatively. For example, the ICP monitoring thing. See, we have best practices, global best practices, isn't it? You can never take what is in America or in UK and bring it to Nigeria and say, oh, start one of them. No. You must think globally, but you must adopt and adapt it locally. Public hospital, you see the complex neurosurgical case, we are delivering good outcomes. It's not because we are doing what they do in UK and stuff like that. Andrew. It's not because we are doing it, it's because we sit down and we think, how can we use it with our limited resources and stuff like that? God bless you all. God bless the organizers of this program. And like I always say, for example, thank you. I'll be running very soon.